This presentation is a case series. A case series of metformin-associated lactic acidosis following metformin overdose. Authors are Hettiarachchi NM, Manilgama SR, Sirisena PW, MSS, Jayasinghe IK, Thenura TW PK, and the paper will be presented by Hettiarachchi NM.
Good evening, ladies and gentlemen. I'm Dr. Madhuvanti Hettiarachchi, Specialist Physician in Internal Medicine, Teaching Hospital, Peradeniya. I'm going to present a case series of metformin-associated lactic acidosis or MALA following metformin overdose. Metformin overdose is relatively uncommon. Metformin-associated lactic acidosis or MALA is a potentially fatal rare complication. The toxic dose of metformin is unknown. Levels do not correlate very well with the clinical presentations. However, higher levels are associated with dire complications. If not recognized and treated early, it can be life-threatening. What are the treatment options available for MALA? Intravenous fluid, sodium bicarbonate loading dose and infusion in patients with an indication, mechanical ventilation and cardiovascular support, correction of hypoglycemia and other electrolyte abnormalities, and hemodialysis in selected cases and treatment of underlying conditions are considered the mainstay of therapy. Intermittent hemodialysis or SLAD, sustained low efficiency dialysis with bicarbonate containing dialysate, produces a higher clearance of metformin than continuous veno-venous hemofiltration or hemodiafiltration, according to the group studies done in most centers. Few case studies have tried HIGH therapy, which is high insulin euglycemic therapy that act by reducing lactate, improving pH, and patient's clinical condition. Present case histories, management, and outcome of 5 patients who presented in MALA following severe overdose to a toxicology unit, Teaching Hospital, Peradeniya, Sri Lanka. Let's discuss patient number 1. A 16-year-old previously well girl admitted 6 hours after self-injection of 112 tablets of metformin. She complained only of mild epigastric pain on admission. She was hemodynamically stable. pH value was 7.08. Her lactate is more than 13 millimoles per liter with a base excess of -22. Her random blood sugar was 243 milligrams per deciliter. We have offered her HDU care, IV fluid boluses and maintenance, and hemodialysis was arranged 12 hours after injection of metformin. Patient developed hypertension soon after the dialysis and noradrenaline infusion was started. Sodium bicarbonate infusion was also continued until CRRT was arranged. Her clinical condition deteriorated gradually. pH was 6.8 and the lactate levels were persistently more than 15. The elective intubation has to be done. She was started on CRRT only 20 hours after injection of metformin due to practical issues. And she was on maximum doses of 4 inotropes. Despite that, she developed acute kidney injury, liver injury, deranged clotting profile, and prolonged hypertension and DIC. And she was given best of care at the ICU with all the possible treatment modalities. Though after 72 hours of CRRT, her hemodynamic, biochemical, and blood gas parameters were improved, patient succumbed due to multi-organ failure and possible sepsis on day 8 of metformin injection. Patient number 2 was a 70-year-old man without any significant past history, was admitted to hospital with acute altered level of consciousness, and he had repeated vomiting. There was no history of convulsions, head trauma, or substance abuse. On admission, his GCS was 12, he was tachycardic and hypotensive, RBS was 138 milligrams per deciliter, his pH was 7.18, and lactate level of more than 15 millimoles per liter. We have done a CT brain which was normal, and there was a high clinical suspicion of metformin overdose, and he was resuscitated with normal saline and noradrenaline infusion and dextrose for repeated hypoglycemias. Despite that, worsening pH was seen and lactate level was more than 15. Patient was hemodialyzed. After 16 hours with 2 dialysis, patient's conscious level actually improved with hemodynamics, and patient was admitted that he has ingested handful of metformin tablet which contain about 40. pH improved to 7.3 and the lactate level decreased to 12. He developed acute kidney injury and needed every other day hemodialysis, but patient completely recovered after 18 days. Patient number 3 was a 17-year-old girl, previously well, admitted with self-injection of 40 tablets of metformin 12 hours back, and she had vomiting and generalized abdominal pain. She was conscious rational. pH was 7.17 and lactate was more than 15. But we could arrange the hemodialysis within 4 hours, and her lactic acidosis rapidly improved, and the dialysis was enough. One dialysis was enough, and no further dialysis was needed. She was discharged after 5 days of hospital admission without any complication. A 17-year-old girl transferred 24 hours after ingestion of 50 tablets of metformin. She complained of vomiting, dizziness, and difficulty in breathing. On admission, she had a GCS of 10. She was tachycardic and hypertensive, and her APG was pH 6.8 and a lactate level of more than 15. We have given her IV fluids, inotropes, loading dose of sodium bicarbonate, and an infusion. She was admitted to intensive care unit for CRRT, and after 48 hours of CRRT, her lactic acidosis improved, and she was weaned from inotropes. Our last patient was an 18-year-old girl who was admitted 100 tablets of metformin, and she was conscious, rational, and hemodynamically stable on admission. And her initial ABG showed a pH of 7.32 with a lactate of 10 millimoles per liter. She was started on high dose of insulin euglycemic therapy while carefully monitoring the potassium and replacing whenever necessary. Repeated blood gas showed worsening of metabolic acidosis 3 hours later, and we have started her on hemodialysis, and sodium bicarbonate infusion was also started. Patient was transferred to ICU because the hemodynamic instability was there. CRRT was initiated after 9 hours of ingestion of metformin. Supportive care was continued, and high-dose insulin euglycemic therapy was also continued. And after 24 hours, patient showed improvement in lactic acidosis, and hemodynamic parameters were improved. After 3 days of CRRT and Hyatt, she was transferred to ward, and her acute kidney injury recovered with hemodialysis, and she was discharged after 11 days. In summary, the 4 female patients were between 16 to 18 years of age. Male was 70 years, and minimum number of tablets taken were 40, and while maximum was 112, their duration from ingestion to hospital admission varied between 3 to 24 hours. All of them had abdominal pain and vomiting. On presentation to the hospital, their GCS was 10 or more. 2 of them had low blood pressure on presentation. 2 developed hypertension later. Their APG showed pH varying 6.8 to 7.32. All patients had evidence of severe lactic acidosis despite the time of admission. Serum bicarbonate level varied between 3 to 12 with severe high anion gap metabolic acidosis, except the male patient who had repeated hypoglycemia. Others had normal low high sugar levels. Bicarbonate infusion was started in all patients. Inotropes was needed in 3 patients. 1 patient was offered early Hyatt therapy, was managed without further inotrope support and without much complications. Potassium was carefully monitored and supplemented in that patient. 3 developed acute kidney injury. In that 16-year-old girl who ingested 112 tablets underwent late CRRT. After 20 hours of ingestion of metformin, she succumbed to multi-organ failure and sepsis on day 8 after admission. Hemodialysis or CRRT was offered for the others within 6 to 10 hours. They fully recovered after 5 to 18 days of admission. Conclusion and recommendations. Delay in presentation, severity of the overdose, and delay in starting dialysis was associated with poor outcome, death or prolonged ICU stay. It is also noted that initiation of early HD shows good overall prognosis. Hyatt, which has shown to be effective in metformin toxicity, worked in our patient as well. Further studies are needed to show the efficacy of early initiation of SLED in Mala patients before they develop cardiovascular compromise and renal impairment. Place for Hyatt therapy also should be evaluated. These are my references. Thank you very much. Thank you.
Thank you, Dr. Hettiarachchi, for the presentation. The paper is open for discussion now.
Dr. Hettiarachchi, thank you for the presentation. I'm intrigued by the fact that 4 out of the 5 patients in your series, they are very young, 16, 17. So are these all suicidal intent and tablets of some other person's tablets that they have taken?
Because, you know, during the COVID lockdown, madam, actually they have posted, most of the centers have posted stocks for about 2 months. So these are somebody else's tablets, actually, parents or, you know, grandparents. And the lot was quite, I mean, like it was around 100 to 40. So it varied from 40 to 100. So because they were, they have access to a lot of medications at that time, I think they have taken all those. So when they came to the hospital, they were actually very ill, most all 4 of them.
So they were all depressed as well?
Actually, most of them were only 1 or 2 were depressed. Those were acute reactants, acute reactions with the disputes of the with the parents, and just minor stuff, not very. They were not depressed, only one patient was depressed actually. We have done a psychiatric referral for all of them. Yeah.
Thank you.
As there are no questions, shall we move to the next presentation? The next presentation is emotional intelligence and its possible association with some selected social demographic factors, academic performance, and extracurricular activities of medical undergraduates from a selected government medical school. Authors are Sandakumar GVN, Dedigama DAD, Vetasingha P, Veeratna KC, Veerapudi DSP, Jayasingha S, and the paper will be presented by Sandakumar GVN.
Good afternoon, ladies and gentlemen. My name is Dr. Indika Vetasingha, and I'm here to talk about our study titled Emotional Intelligence of Medical Undergraduates and Possible Associations. So it was a study that was conducted among medical undergraduates from a selected medical school in Sri Lanka. So we are very familiar with the term IQ, but EI, or emotional intelligence, is defined as the capacity of recognizing our feelings and those of others. So it is something different to IQ. And it consists of 3 components: sensitivity, maturity, and competence. So we all know that the medical field is highly dependent on human interactions. Whether it is eliciting a history from a patient, answering the concerns of a patient, or taking consent from a patient, or even breaking bad news, the human interaction is vital. And studies have shown that doctors who practice empathy are more likely to arrive at an accurate diagnosis and elicit a good history. And even their patients are more effective in the compliance to the treatment. So the general objectives of this study was to assess the emotional intelligence among the medical students. And we also assessed the relationship between emotional intelligence and social demographic factors, the association between emotional intelligence and extracurricular activities, and the association between EI and the students' academic performance. So it was a cross-sectional study which included medical students of 6 batches from a selected faculty in the Sri Lankan University. One must note the senior most batch were participating in the final MBBS exam, so they could not take part in this study. Simple random sampling was done and data was collected using a self-administered questionnaire. This questionnaire is an internationally validated questionnaire developed by Dalip Singh and Chada NK. And it consists of 22 questions, which are actually situations in an MCQ format. So 5 situations assess the sensitivity, 7 situations assessed the maturity, and 7 situations assess the maturity, and 10 situations assess the competency. So this is an example of the type of questions that were present in this questionnaire. So when you come to the interpretation of the scores, each dimension of emotional intelligence is again divided into extremely high EI, moderate EI, and low EI. So the sensitivity is scored out of 100, maturity is scored out of 140, competency out of 200, and of course the total emotional intelligence in a study was scored out of 440. The sample size of our study is 384 with a response rate of 91, and 70% of the population were females. So we found that the emotional intelligence among the participants was fairly good, was in fact pretty good, with majority of the participants scoring an high EI or an extremely high EI, the only exception being sensitivity, where 56% of the population had a moderate EI. So there was no statistically significant relationship between the mean EI score and the batch, which meant that there was no relationship between the number of years spent in university and the mean EI score. But even though there was no statistical relationship, we can see, we compare the means that the senior batches, the 24th, 25th, and 26th batch performed better than the junior batches in all three dimensions. With regard to sensitivity, the females scored a higher mean EI than males, and this is statistically significant. So the females were more sensitive to the issues than the males. The females also scored a higher competency score, and the total EI was higher than males. With regard to the relationship between the mean EI score and the family income, the students whose families had a monthly income of more than 40,000 Sri Lankan rupees had a higher sensitivity and a higher competence, and therefore a higher total EI score. The students who were coming to university from boarding or hostel had a higher maturity and a higher competence score than students who were coming from their own residence. So the students who participated in sports scored a higher emotional intelligence score in all three dimensions when compared to students who did not participate in sports. And the same findings were found in societies, where the students who participated in societies scored a higher mean score in all three components of emotional intelligence when compared to the students that did not participate. So the relationship between the mean EI score and the performance in the first MBBS exam. So we can see that the students who obtained a class in the first MBBS had a higher total sensitivity, a higher total competency, and their total emotional intelligence was also higher than those who did not obtain a class in the final MBBS. And with regard to sensitivity, the difference was statistically significant. So there was a statistical significant difference between the students who obtained a class and the students who did not obtain a class. So in a study, we found that the emotional intelligence among the participants was good, with the one exception of sensitivity. And those who participated in extracurricular activities such as sports and societies had a higher emotional intelligence score in all three dimensions. And we also found that the students who obtained a class in the first MBBS had a statistically significant higher score for sensitivity and also a higher score for competence and total EI. So these are our conclusions. And we would like to emphasize that unlike IQ, EI can be improved with deliberate training. And we have seen that universities promote students to take part in extracurricular activities and also programs such as personal and professional development. And from our study, we can see that they're actually moving in the right direction. And we would like to emphasize more on this aspect. So that concludes my presentation. Thank you.
Thank you, Dr. Vetasinghe. The paper is open for discussion now.
Thank you, Dr. Vetasinghe. It's an interesting presentation. What is your explanation for the higher sensitivity and competency of females? Do you have one?
Well, to be honest, madam, I do not have an explanation for that. So that is what we derived from the statistics. So clearly there is some relationship between sensitivity and gender, which is statistically significant. Maybe it's the social upbringing. I'm really not sure regarding that.
Thank you.
Right, in the absence of further questioning, let's move to the next presentation. The next presentation is adverse event following first dose of COVID-19 COVID-Shield among healthcare workers in Sri Lanka. Authors are Malingam SR, Hettiarachchi NM, Jayasinghe IK, Da Silva S, Jayalathi, Vanigaratna T, Bandusiri RP, Suganthan N, Sudarshan P, Pathirage M, Rajaratna N, Senaratna G, Rajapaksha V, Vikrasinghe A, Kulavira MTD, and the paper will be presented by Malingama SR.
Good morning. I'm Dr. Suranga Malingama, specialist physician in internal medicine, currently working at Colombo North Teaching Hospital. I present the study which was conducted to assess the prevalence of adverse events following the first dose of Covishield vaccine among healthcare workers in Sri Lanka. A community vaccination program is the best approach to combat COVID-19 pandemic. The priority was given to healthcare workers with the introduction of vaccination to Sri Lanka in February 2021. An independent post-vaccine surveillance is important to identify the occurrence of adverse events in the population. Objectives of the study were to assess the prevalence of adverse events following immunization. The term used is AEFI of the first dose of Covishield vaccine among healthcare workers at selected government hospitals in Sri Lanka. Adverse events were categorized as major and minor, and systemic and local events. To assess the association of common comorbidities with the adverse events, to assess the short-term outcome of the adverse events among the healthcare workers. We conducted a multi-center cross-sectional survey. The study population included all the staff of selected hospitals who received the Covishield vaccine. It was conducted in 8 secondary and tertiary care institutions in 6 provinces of Sri Lanka. Institutions are as follows. Participants were invited to fill in self-administered questionnaire in the language of their choice after the first dose of vaccine. This was done within 6 weeks of vaccination. It took approximately 15 to 20 minutes to complete the questionnaire. Ethical approval and institutional approval were taken from relevant authorities. Let's look at the results. 5,140 participants completed the questionnaire. 67.8% were females. Only 31 persons has had COVID infection in the past. 2.2% of the population were breastfeeding mothers and 0.2% were pregnant ladies. The mean age was 40.69 years with SD of 10.07 years. The comparison of healthcare workers were medical doctors 17.6%, nurses 36.4%, healthcare assistants 22.9%, and paramedics and other supportive staff represented the rest. At least one comorbidity was reported in 18.8%. Distribution of comorbidities among participants are shown here, but there were no significant association between having a comorbidity and developing systemic or local effect. Comorbidities showed a significant difference across age groups. 13.3% had history of allergies, while only 6% had history of anaphylaxis. Study population was divided into 2 groups according to the mean age of 40 years. Younger age group was equal or less than 40 years, and older age group was more than 40 years. The categorical variations were compared using chi-square test, and continuous variables were compared using student t-test between 2 groups. Reactions occurred within first 20 minutes in 2%. Anaphylaxis developed in 12 patients, was considered as major adverse event, and all treated successfully. 0.8% developed urticaria. History of anaphylaxis, drug or food allergies did not show significant relation to current vaccine-induced allergies or anaphylaxis. 86.6% of persons had at least one adverse event, and 49.3% had local adverse event. Most reported systemic events are as follows. Fever and headache are the most reported systemic event. Fever was recorded as low grade and high grade. That is shown in the same bar in 2 shades. Fever and age showed significant difference. Headache was recorded as mild, moderate, and severe. occurrence of headache and age category showed significant difference. 38% in younger age group and 33% in older age group had mild headache, while in 6% each of both groups had severe headache. Occurrence of adverse events like feverish, rigor, and body aches were more common in the younger age group. When it comes to local adverse events, pain at the site was the most reported local adverse event. Several systemic: fever, feverish, rigors, nausea, fatigue, and itching. And all local adverse events were significantly higher among the equal or less than 40 years age group than old age group, while chills, headache, and body aches were not significant. When we talk about mean onset time of adverse events, mean onset time of fever was 6.65 hours. Mean onset time of pain at site was 9.67 hours. Adverse events developed early in the younger age group. Onset time of fever, headache, body aches, joint pains, itching, and fatigue showed significant difference among two age groups. Systemic effects last for 24 hours in average. Fever lasted for 14.57 hours in younger age group and 20.16 hours in old age group. On the contrary, adverse events lasted more in the old age group. Fever and headache showed significant difference between two age groups. Averagely, the pain lasted at the site for 4.5 hours. Though the onset of fever and headache was earlier in younger age group, the duration of both fever and headache were much longer in older age group. Both onset and duration showed significant difference between two age groups. Outcome after the vaccination also studied. About 2/3 attended to the routine work despite having minor reactions. About 0.2% were hospitalized and treated. This graph shows the outcome. 22.4% were stayed at home and rested for 1 to 2 days. Outcome was favorable in the age group of more than 42 years and showed a significant difference across two age groups. In conclusion, incidence of most of the systemic and all local adverse effects were higher in the young age group. Though the onset of fever and headache was early in the young age group, the duration of both fever and headache lasted was much longer in old age group. Both onset and duration showed significant difference between two age groups. Majority reported minor adverse events. Only a few had serious adverse events. Overall, the first dose of Covishield vaccine was well tolerated by healthcare workers. Community-based vaccine surveillance is mandatory to identify new onset adverse events. Establishment of such system as a part of routine vaccination program is recommended. Thank you very much.
Thank you, Dr. Maligama. The paper is open for the discussion now.
Thank you, Dr. Maligama. You said that 12 patients experienced anaphylaxis. How many of them gave a past history of allergy?
Madam, there was no association between current vaccine-induced allergies or anaphylaxis with previous history of anaphylaxis or allergy, and none of them has had an anaphylaxis for previous events, and this was the first event.
Thank you.
Thank you, Suranga. Do you have any explanation for this age difference? And the other thing is whether you have any idea whether in the community also whether it's the same differences existing, like in the non-healthcare workers.
Yeah, initially we wanted to study that as well when we were planning to do the study on healthcare workers. So our next plan was to do extend the study to the community, but unfortunately we could not carry out that due to some practical problems. according to the patient's experience that we have come across, they also said that the younger patients has had more side effects than older patients, older people. But in other community, in our country, they were given Sinopharm instead of Covishield, and old age group has got Covishield vaccine. I think that was the main reason we could not compare the same vaccine among two age groups in public.
Okay, right. Thank you.
Thank you, Dr. Maligama. As there are no other questions, we'll move to the next presentation. The next presentation is improving decision making and documentation regarding advanced resuscitation decision in a tertiary care center in Sri Lanka. Authors are Appuhami S. Hevagedi, and the paper will be presented by Appuhami S.
Greetings, everyone. We are glad about the opportunity given to us to present the findings of our clinical audit in this prestigious forum. We conducted a clinical audit titled Improving Decision Making and Documentation Regarding Advanced Resuscitation Decisions in a Tertiary Care Hospital in Sri Lanka. This was done in the Professorial Medical Unit of the National Hospital of Sri Lanka. I'm Shanala Appuhami. Let's walk through the findings of this audit and their interpretation. To start with the basics, advanced resuscitation decisions provide the mechanism to predetermine the best resuscitation strategy for persons at risk of death based on their individual circumstances. Resuscitation strategies include, but are not limited to, cardiopulmonary resuscitation, meaning whether or not to perform CPR on a patient who suffers cardiopulmonary arrest. In most circumstances, there should be a shared decision between the treating clinician and the patients. However, we acknowledge that these decisions are difficult and the discussions around these are uncomfortable for both parties. But lack of early and prompt communication lead to poor patient outcomes at the end of life, and may also be a source of litigation against doctors. Defective documentation of any decisions that were made can similarly lead to poor care outcomes. The main aim of the study was to analyze and improve the decisions around cardiopulmonary resuscitation in our unit. So after obtaining the relevant ethical, institutional, and unit approvals, the first step was to develop an interviewer-administered questionnaire to analyze the deaths. This was developed through a small focus group discussion, which comprised of several specialist physicians, and was based on the 2016 joint guidelines on resuscitation decisions by the BMA, the RCN, and the Resus Council of the UK. And this was used to analyze the deaths that occurred over a period of 2 months. The questionnaire consisted of 2 parts. The first part was designed to thoroughly analyze the medical records with regard to resuscitation decisions, and the second part was an interview between with the junior medical officers who were directly involved in the care of the patients during their last admission. These medical officers were interviewed to determine their professional opinion regarding the most appropriate resuscitation decision in each individual case regardless of what was actually documented or what was actually done at that particular time. On the other hand, we had a panel of experts consisting of 3 consultant physicians and 2 senior registrars who thoroughly analyzed the medical records of these deaths based on the above said guidelines to determine the most appropriate resuscitation decisions in each individual case, regardless of what was documented or what was practiced. And finally, we had the decisions of the junior doctors compared with that of the expert panel. The main intervention was an educational session in the format of a series of lectures with the participation of 18 doctors. And the main aim was to improve the knowledge among junior doctors about the concept, as well as trying to motivate the senior doctors to practice more and more advanced resuscitation decisions. A pre-printed form was introduced at the same time to document advanced resuscitation decisions. The part of the questionnaire, this is the opening slide of the presentation, the study session, educational session, and this is the pre-printed form which was designed to document resuscitation decision. And we re-audited the same study setting after 2 months of the intervention using the same methodology. And overall, we analyzed 78 deaths, 40 in the pre-intervention period and 38 that occurred during the post-intervention period, and these are the baseline characteristics of the groups. We observed a significant improvement in the number of clearly documented resuscitation decisions in the post-intervention period compared to the pre-intervention period. And we also observed a significant improvement in the number of do not attempt CPR decisions. Probably as a result of this, unsuccessful CPR attempts reduced significantly by more than half in the post-intervention period, and a significantly high number of resuscitation decisions suggested by the junior doctors during the post-intervention period matched with the decisions of the expert panel. There were several other interesting findings. A high number of failed decisions were observed, which did not translate into action. CPR was performed on patients even when a clear documented decision was there not to perform CPR. The pre-printed form was not filled in the majority of cases. However, there were some decisions that were recorded directly in the bedhead tickets. There was only little improvement in the resuscitation decisions other than those around cardiopulmonary resuscitation. Unfortunately, none of the discussions involved the patients. They only happened between the clinicians and the family or surrogates. Sorry. And none of the decisions were reviewed after they were initially taken. However, no legal actions were taken against any of these. In conclusion, the practice of advanced resuscitation decisions is still poor in Sri Lanka. But the good news is simple interventions like improving the knowledge of junior doctors about these and standardizing documentation can improve end-of-life care outcomes for most patients. However, larger studies are required to confirm these findings. Based on the study, we recommend that further measures should be taken to improve the knowledge of junior doctors about resuscitation decisions, and steps to reduce to introduce standardized documents at national level are most likely to improve end-of-life care outcomes for most of these patients. Thank you.
Thank you, Dr. Appahami. So the paper is open for the discussion now.
Yes, Dr. Shanal, I think what you meant by the category of doctors as junior doctors is, I suppose it's mainly the intern house officers, is it?
Yes, sir. We included both the registrars and the intern medical officers as junior doctors because we don't have resident medical officers in our unit. So yeah, well, the junior senior that was actually an arbitrary sort of cutoff. We took. We included the senior registrars and the consultants as senior doctors and the others as junior doctors. That's what we did. Yeah, but that's just us. We didn't find it anywhere else. It's
Dr. Appahami, thank you for the presentation. What are your plans to disseminate your recommendations? Do you have any plans to disseminate them widely for the information of the decision makers so that they'll be picked up by those who matter?
Yes, madam. Actually, I actually wanted to conduct a larger study on this because I think one of the major drawbacks was I could not actually implement this the pre-printed form appropriately as I wanted to. Because it was filled, I'm not sure whether it's mentioned in the presentation or not, but it was used only in 35% of the cases. So most of the patients did not have that pre-printed form filled for us to come into a conclusion whether this actually helps or not. So I think we have to first conduct a study on that, and then we can disseminate the findings of particularly with regards to the pre-printed form.
Thank you.
Thank you, Dr. Appahami. As there are no other questions, we'll move to the next presentation. The next presentation the next presentation is identifying host markers of dengue disease severity, a mass spectrometric based approach. The authors are Perera N, Kumara A, Gangadharan B, Vijay Vikrama A, Malavige G N, Miller G L, Sitzman N, and the paper will be presented by Perera N.
I'm Nilanka Pereira, presenting the study on identifying host markers of dengue disease severity. Dengue is a problem worldwide as well as in Sri Lanka, and although the case fatality rate is less than 0.3%, still it causes significant morbidity and mortality. Mortality is mainly due to dengue hemorrhagic fever, which causes fluid leakage. And these patients need close monitoring and in-hospital management. And the problem is we still do not have a predictive marker which can identify patients developing dengue hemorrhagic fever during early disease. Our study was based on peripheral blood monocytes, which is an important target of infection in dengue as well as a mediator of inflammation. And there are no studies done to look at the proteins in these cells of infected patients in dengue hemorrhagic fever comparing to dengue fever published so far. So we used a proteomics approach, that is identifying proteins based on the mass, and then we did a mass spectrometry, so we were able to identify all the proteins in the cells of these patients. And then we used a technique called TMT tag, so that was multiplexing and labeling these samples so that we were able to compare the protein levels amongst the samples as well. So our objective was to identify proteins differently expressed in PBMCs of patients with dengue hemorrhagic fever during the first 72 hours of illness. And we want to see whether we could identify a potential marker which could predict dengue hemorrhagic fever during early disease. And also by using the proteins that are expressed in the cells of DHF patients compared to DF, we want to see whether we could also understand the disease pathogenesis better. So this was an experimental study, a 10-plex TMT mass spectra study. And we conducted the study in the infectious disease hospital and then conducted mainly the experiments in University of Srijawardena and University of Oxford. The study was done in 2018. We recruited patients with a febrile infection during the first 72 hours of illness, and they had to have a confirmed dengue fever. So NS1 was positive on recruitment, and further dengue PCR was also done to confirm infection. And age less than 18 years, the pregnant patients, and patients who had any evidence of fluid leakage on recruitment were excluded. Patients were then followed up to see whether they developed dengue hemorrhagic fever or not. So patients with a positive NS1 antigen by a rapid kit on recruitment had 7 ml of blood collected to a heparinized tube. And then these peripheral blood monocytes were isolated using a Picot gradient approach, and then we lysed these cells and then used them for the mass spectrometry. And these patients also had a further 3 ml blood collected to identify the dengue genome by a PCR. So there were 15 patient cell lysates which were viral PCR positive, and we used 10 samples of these for the analysis based on the highest protein content. And then we also used 2 healthy controls for the analysis. So 4 dengue fever and 4 dengue hemorrhagic fever samples, and we identified the proteins using mass spectrometry. So there were 7,351 peptides identified in these samples. And because there are more than one peptide for a protein, these constituted 1,930 proteins. So then we looked at these identified proteins and then identified the proteins that were more than 2-fold different in the DHF samples, so either up or down regulated. So that constituted 167 peptides, which constituted 92 proteins. And these are the 92 proteins differently expressed in the DHF cell lysates during the first 72 hours of illness. And then we use the list of these proteins to see what sort of pathways.
Good morning, everyone. I'm going to talk about cardiac CT or coronary CT angiography in clinical practice. By trade, I'm a radiologist. I work in the UK in East Anglia in a small coastal town called Kings.
Next presentation is a
several pathways related to cytoskeleton organization related to actin signaling or actin filament formation. So this has not been previously identified in clinical samples or described in dengue fever, although there are some reviews and in vitro studies suggesting that flaviviral infections and dengue could affect the cytoskeleton formation and possibly actually lead to vascular leakage from these mechanisms. So this is something we identified from a study. So after identifying these 92 proteins and the pathways, we also did further statistical tests to see whether these were significantly different among the 4 DF samples versus 4 DHF samples by using either the t-test or the Mann-Whitney test. And although these were just 4 samples, which might be used to reduce power, still there were 21 proteins which were significantly different in the DHF cell lysate. So these are the proteins that are highlighted in dark color and also in bold. So I have shown here 5 proteins which had a p-value less than 0.01, and probably can identify that dengue hemorrhagic fever samples, the 4 samples had significant lower levels of these proteins compared to dengue fever samples. And these other 15 proteins also were significantly either low or high in the DHF cell lysis within the first 72 hours of illness. And we also used further databases to see whether these proteins can actually be detected in the serum as well. Although we did the study in the cell lysates, there were 9 proteins which has previously been detected in the serum, so potentially secreted from the cells, and that is very convenient as a test for identifying proteins. So these 9 proteins which were significantly different could also be detected in the serum itself. So in conclusion, we have identified 92 proteins which are different in the monocytes of dengue hemorrhagic fever patients during the first 72 hours of illness before they developed through leakage. And there were 21 proteins which were significantly different, 6 upregulated and 15 downregulated. And there were several biological pathways which we identified, which needs further validation as well as experiments to identify the relevance in a dengue hemorrhagic fever pathogenesis. And there were 9 proteins which can be detected in serum as well. So this study provides a flat platform to further validate these proteins as markers to predict severe disease. And also we can use these proteins and the pathways to understand the development of vascular leakage in dengue hemorrhagic fever, which is still elusive. Main limitation was the 4 samples that was used in the study. Thank you.
Thank you. Thank you. The paper is open for discussion now.
Yes, thank you for an interesting presentation. Now, just one example, one question. Now, what is the time duration from the time of getting the blood vivisected to time to get the report, lab report? I mean, if we take about more than 5-6 days, I don't think it's practical. And what is the shortest time duration that you can show that this particular protein is present or it is in excess or something like that?
It's a good question, sir. So our study was done in cells. So because we wanted to identify proteins and then see whether these could be detected in serum as well. So once validated, if we can actually find a good protein in the serum, this could be an ELISA, which could take, let's say, 4 hours, 5 hours for an ELISA. And furthermore, if we do have a good test, we can also even develop a kit, a rapid kit down the line. So that would actually be a kind of a point of care test as well.
All right. Thank you.
Thank you, Dr. Pereira. I mean, it seems like a very important finding, your study. Why has these biomarkers been not identified in the past? Are there any other studies in the past that have been done? Similar
Yes, ma'am. So biomarkers have mainly been done in the serum, and there are only few studies done in clinical isolates of cells. One of the problems in serum, I feel, is like because there are so many proteins, even proteomic studies, it's difficult to identify low abundant proteins. So most of the time it's masked by the high abundant ones. But there are some markers which has gone through in experiments but not been validated enough. And this is the first one done in actually monocyte kind of infected cell. I feel like because of the variation of these biomarkers or any marker, because patients are very heterogeneous, and unless the marker is quite a robust one, then the validity or the sensitivity or the specificity would be in question. So that has been one of the problems, even inflammatory markers, because it's quite a variation. So I think it should be a robust marker, and I'm quite actually we are very happy with this 21 because it's just in for sample comparatively, but even there could be others in among the 92. So I feel it should be a robust one and validated in a very large sample for it to come out actually as a test.
Thank you.
Thank you, Dr. Pereira. Let's move to the next presentation. The topic of the next presentation is humoral immune response to 2 doses of Covishield vaccine among healthcare workers from a teaching hospital in Sri Lanka. The authors are Senaratna UG, Dayanath BKTP, Helangoda S. Pulyadasa TMNK, Thalgaspitiya TNK, Pereira KKTH, and the paper will be presented by Senaratna UG.
As the Department of Chemical Pathology of the Colombo Teaching Hospital, Ragama, we conducted this study to assess the humoral immune response to 2 doses of Covishield vaccine among healthcare workers at our hospital. Since the first case of COVID-19 reported from China, 252 million have been infected, with the number of COVID deaths reaching 5 million to date, making COVID-19 the biggest threat we faced in the 21st century. So how do we face it? Since the vaccination is a well-proven method to control the morbidity and mortality associated with infection, the world has embarked upon vaccination to fight against this pandemic. So, in response, vaccines were developed within a very short period and authorized to be used in mass immunization campaigns worldwide. In Sri Lanka, vaccination campaign was started from the healthcare workers using the Covishield vaccine. So why should we assess this vaccine efficacy? There are always doubts when you are faced with a new product, especially if you are required to inject it to your body. Sri Lanka, being a country with a well-established national immunization program with good public acceptance and compliance, assessing and showing the vaccine efficacy among the public themselves can improve the public opinion and their acceptance. Further, it is important to assess the persistence of its effect to ensure the long-term protection against the infection. So, our team embarked upon this study to assess the vaccine efficacy among our own community. The vaccine efficacy can be defined as the percent reduction in disease incidence among vaccinated compared to unvaccinated under optimal conditions. And it is ideally assessed by direct measures of reduction in disease incidence in randomized controlled trials. However, a simple and convenient alternative that can be applied in the clinical settings, especially in an observational approach, would be the immune signature, which assesses the vaccine-induced antibody development in the host, which we have applied in our study as well. So, we aim to assess the immunogenicity of 2 doses of Covishield vaccine based on the antibody development in the host using a cohort of healthcare workers. From the 177 subjects recruited in the study, blood samples were obtained 3 to 4 weeks after each vaccine and just before the booster dose. The Covishield vaccine, being a viral vector vaccine using genetic information on COVID spike protein to induce the host immunity, we selected an assay specifically designed to detect antibodies against the spike protein. Thus, serum was analyzed for COVID IgG antibodies using an FDA-approved 2-site sandwiched chemiluminescence immunoassay developed by Orthoclinical Diagnostics. Results. Our study group contained 60% females and the mean age was 44 years. The majority of the subjects were less than 55 years and 50% of them belonged to the middle age category. And none of them had any history of PCR positive COVID infection at the time of inclusion in the study. A majority seem to have developed post-vaccination symptoms after the first dose, such as fever and myalgia. When we measured the antibody levels, the study participants had a good antibody response after a single dose of vaccine with a mean antibody index of 5.8 and overall seroconversion of 82.5%. The highest seroconversion rate was observed among the middle-aged, while the elderly had the lowest seroconversion rate. However, the seroconversion significantly reduced by the time of the second dose, that is, 12 weeks after the first dose. As expected, seroconversion increased significantly after the booster dose with an overall seroconversion of 98.9%. However, there were 2 participants more than 55 years who failed to achieve seroconversion in our study group. And this graph depicts the antibody response against the timeline. We assumed that antibodies were absent in the non-infected, as none of the participants had any history of PCR positive infection at the time of recruitment to the study. As you can see here, the mean antibody levels had increased following the first dose and dropped by the time of the second dose, and again increased after the second dose. Moving on to discuss our study findings. Being a viral vector vaccine, it was explainable that a majority of participants experienced post-vaccination symptoms similar to that of common viral infections. Seroconversion following a single dose of vaccine was observed among a majority of our subjects, a similar finding to Jeevandara et al., a large-scale study conducted in Sri Lanka assessing the response to a single dose of Covishield vaccine in 2021. We further observed that although the antibody response was good, it significantly reduced 12 weeks after the first dose. However, seroconversion increased significantly by the second dose of the vaccine. Therefore, although seroconversion significantly increased after the booster dose, the future trends are questionable if it is going to increase or decrease. Therefore, our conclusion is that it is important to assess the immune signature in long term to ensure the persistence of adequate immunity against COVID-19. These were some of our major references, and thank you.
Thank you, Dr. Senaratne, for the presentation. The paper is open for the discussion now.
Dr. Tilak, you are muted.
Right. Okay, sorry. Can you hear me?
Can hear you now.
Yes. Now, I just want to know this lower seroconversion rate with increasing age. Is it a known finding with other vaccines as well, or it is not peculiar to Covishield or any other viral?
No, it was a similar finding to other studies as well, sir.
Yeah.
In the study that I mentioned by Dr. Jeevandara et al., they have also had the same similar findings, and I personally know another study that was done, which is not yet published. They also had the same findings, similar findings.
Right. Thank you.
Yes, thank you, sir.
So I believe there are no more questions to ask. So with that, we will conclude the session on oral presentation of the research publication of this year. Thank you for all those who presented in this forum. And also I would like to thank three judges for their valuable contribution. Thank you very much for all. Vinod, can we remove all the presenters, please?
I would like if all the presenters would leave the session right now, and then we could proceed to the session afterwards.